Gibson's GuidePoint Survey Results webinar. Our event today will be 60 minutes long. Everyone is muted and will remain that way for the duration of the event. However, we do want to answer your questions. So please either use the chat or questions feature within GoToWebinar. And it's part of your tools, and you'll send the questions directly to me, the meeting organizer. I'll forward your questions to Wes, and he'll do his best to address them as he goes along. Worst case scenario is he will address the remaining topics at the end. If you have a specific question that pertains only to your company, we'd be happy to address those on an individual basis after the event. We will be recording this event and will make it available to you afterward for future reference or for sharing with others in your organization. It is my pleasure to now introduce Wes Mantooth, Principal and Employee Benefits Practice Leader. Wes?
Terrific. Thank you, Tanya, and good morning, everyone. As Tanya said, welcome, and we greatly appreciate your time this morning. And thanks to those of you who were able to participate in the survey this year. We truly appreciate it. And we will be sending you your individual GuidePoint survey report this afternoon. So shortly after this webinar this morning or this afternoon, we will get it to you. In addition to changing the look of the survey for 2014, we also transitioned the foundational benchmark data to Kaiser this year to provide a broader, more credible reference point. And in so doing, our intent was to make the process more user-friendly for you while also making the output more valuable. And once you've had a chance to review your individual report, we'd love to hear your feedback as to whether or not we accomplished this. So a little info about Gibson. We are a 100% employee-owned organization, just surpassed 100 employees earlier this year. We were recently selected as a Best Places to Work in Indiana for the second year in a row, of which we are extremely proud of. And as you can see down there at the bottom of the slide, consistently ranked in the top percentiles on both a local and national basis. So as we go through the information this morning, I want to share a few minutes with you talking about healthcare reform. I'm not going to get too much in the mud on that, but just a quick refresher as we get closer to 2015 and a lot of this comes into play and turns into reality. We'll obviously talk about the survey results, and Nicole Fallowfield, our Director of Health Risk Management, will join us later in the webinar to talk about some of the trends and evolution of population health management. And I will finish off by talking about some of the trends in general in the marketplace. So let's get started, and here we go. Healthcare reform. It is here. It's not going away, and as I mentioned, we're not going to get too much in the mud today, but want to touch on a few points here. And if you have any specific takeaways specific to your organization, as Tanya mentioned earlier, please feel free to reach out to us after the call, and we will address that. This is not a typo up at the top. I've caught a lot of flack for this. This is a friendly reminder, not a friendly reminder. I think we'd be giving it too much credit if we call it a friendly reminder. But my first point that we have professed for some time now is please, please manage the hours your employees work now to where you want them to be, and don't be caught measuring them when we get later in the year to find out where they are. We want to minimize surprises as much as possible. So manage. Communicate this to your directors, communicate this to your managers to ensure that they understand what we are trying to accomplish. And the more you can do this verbally, the better. The less in writing, the better there as well. So please manage as best you can now, so we're not in a situation to be surprised come October, November of this year when we are doing the measurement and look-backs to determine what the additional liability may be. There was some momentum for a while in talking about the minimum hour requirement being 40 hours. That had steam back earlier this year and has slowly faded to where there's really nothing out there on that right now. So we are still going under the guise that this will be a 30-hour requirement, so those employees working 30 hours or more would be made eligible for benefits. From a reporting standpoint, there will definitely be required reporting to validate those who do or don't work 30 hours or more. But again, please don't go into that process blindly when we're going through the analysis. Just want to plan ahead of time as best we can. The employer mandate, as many of you know, just a quick reminder for those with 100 or more employees must comply in 2015. And for those with 50 to 99 employees, we have a bit of a break until 2016. And for those who may be considering dropping coverage altogether in 2015, you have 80 freebies that won't count against you in that $2,000 penalty. So again, quick example here, if you have 125 employees, decide not to offer health insurance, first 80 are free, so instead of paying $250,000, that being 2,000 times 125 employees, we're going to pay $90,000, which would be 2,000 times 45. And then in 16, we default back to the 30 freebies. Also in 2015, we have a bit of a transitional relief in that we are required to offer benefits to 70% of our eligible employees, and in 2016 that bounces back up to 95%. This is one that we strongly encourage not planning for, and using that 5% buffer is kind of a excuse me, an exception in 2016 if there happen to be a few individuals that slip through the cracks and were not offered benefits when they should have been. Again, we have a bit of a buffer factor here, so use that for those situations as opposed to planning and selecting against a few individuals. Affordability. Here's some late breaking news for you. This will get everyone excited. That instead of the affordability being at 9.5% in 2015, it has been bumped all the way up to 9.56% in 2015. That just came out earlier this week. So there's some fun, exciting information for you to start your Thursday morning. Subsidies, within the past week or two, you've seen all over the news this scuttle about the one of the district courts coming out and saying that subsidies are not should not be eligible in those states where there is not a state-run exchange. Well, in the state of Indiana, we are going via the federal exchange and not a state-run exchange, so that would mean that consumers in the state of Indiana are not eligible for subsidies. But this is a long way from any changes, so business as usual. Again, nothing has changed at this point. If and when that does, we will certainly let you know, and you can communicate it as you so wish. That's more just FYI for now than anything, given that the news came out recently, but it is business as usual. The PCORI fee is due today, one of the wonderful taxes that came along with this. As many of you have probably already taken care of this, I know we've had individual discussions with the vast majority of you. We've sent out a number of bulletins on this as well, just to make sure that everybody's in the loop. And as far as the transitional reinsurance fee, more to follow on that. That is due by mid-January of 2015. So some more things to deal with when we come into the fourth quarter, but stay tuned. There's still a lot of clarity left on that. So what are employers doing in response to healthcare reform? And this is going to be consistent to what you've seen in the past couple of years with our survey results. Biggest consideration given to minimize the impact is to continue plan design changes as well as migration of contribution subsidies from dependents to employees. So again, we ensure that employee-only coverage for the least costly plan stays within the affordability provisions. In addition to that, what we are also seeing in the market, in addition to the alternative funding that is mentioned there of going self-funded in the middle column or third column there from the left, the smaller employers are considering joining trusts. For example, the IMA, Indiana Manufacturers Association, recently came out with a small group trust, as well as employers joining PEOs to avoid the effects of community rating. As those groups, again, talking about the trusts, as well as the PEOs, are considered a large group in aggregate basis, which insulates them from being subject to many of the provisions, especially community rating, as a result of healthcare reform. So now for the survey results. Let's go ahead and jump in, and we are going to spend most of our time as we go through the medical plans focusing on PPO and consumer-driven health plans. And for those of you who may have a point-of-service plan or an HMO, we would be happy to provide that information and those details to you after the call. But the vast majority of those who participate in the survey fall into the PPO and CDHP categories. The slide in front of you is very similar to what you've seen in the past, the geographical layout of where the participants fall from southern, southwest Michigan all the way through throughout the state of Indiana. down into northern Kentucky. Slide here, just a quick recap of the past 3 years of the survey summary statistics. And you can see we, back in 2012, we hit a peak there of just over 250 participants. This year we were just shy of 200. Now you can see that over the past couple of years, the number of employees, regardless of companies participating, has remained consistent. But healthcare dollars spent has increased slightly as well. And as you can imagine, there's a mix-up as we go through each year. It's not the same folks participating year after year after year. So there are some adjustments to be made. And we certainly understand and appreciate that there are competing priorities. And there's a lot to do with less resources. So we appreciate the fact that you were able to participate in the survey this year. As I mentioned, we are going to focus, again, on the medical side, specific to PPO and consumer-driven health plans. The legend that you see down at the bottom of this slide is going to stay consistent throughout our discussion today. Where we have the Kaiser data available is going to be reflected in red, and then you'll see the teal colors and the gold color there reflecting the 2014 survey results, 75th percentile, survey median, and 25th percentile. Won't spend a ton of time talking about out-of-network benefits as we go through this, given the breadth and depth of the networks that now exist, for example, the Anthems, Uniteds, et cetera. But the info is included here for your reference and will also be included in your individual report that we will be sending to you. So the median deductible, as reflected in the 2014 survey results, right at $1,000, and this is static from 2013, no change at all. Last year we were at $1,000. This year we're at $1,000. Some interesting tidbit here. Our survey started back in 2006, and at that time, the median deductible was $500. So we have doubled over that 9-year period of time, which probably isn't a big surprise given all of the national statistics that folks pay attention to. But just to give you an idea of what's going on there over that period of time. So we are a bit higher than what we see on the national basis, but not surprising as local employers, especially in the state of Indiana, and we see this a lot, are migrating from the richer insulated PPO plans to more higher deductible plans to create greater transparency for the population. Transitioning now to deductibles for the consumer-driven health plans, we jumped slightly. This year, we were at $2,500 last year in 2013. As you see here, $2,650 in 2014. As I referenced 2006 information earlier, we were at $1,500 back in 2006 when the survey started. So we've seen quite a bit of movement since the inception of the survey, and we continue to see that on a year-over-year basis. And you can see how we compare there on a national scope. A bit higher there, maybe about 20-25% higher. Again, not to be alarming because there are some factors taken into consideration here as it relates to funding of HRAs and HSAs and things of that nature that have an impact on the overall value of the plans. Office visit copays for PPO plans, and as we see there on the left-hand side, the median copay $25. Again, nothing's going to stand out there to be alarming to you. This has remained fairly static in recent years. But one thing I do want to spend a second talking about, if you're not already, would highly, highly encourage you to give strong consideration to having separate primary care and specialist copays and have a spread that's still greater than what we're seeing on these survey results and what they reflect. We want your members to start with a primary care and not a specialist, so give them something to think about. And we traditionally see the specialist copays higher than what we see on the survey. So having that median of $35 compared to the primary care of $25, wouldn't be disappointed to see that even double from 25 to 50. And again, just to give your members something to think about. Specialists are still encouraging folks to get referrals into their system, but don't always require that. So a lot of times your population may have direct access. So something to think about that gives them something to think about. It could merely be cost shifting. Maybe it doesn't change their mentality, but makes it a little bit more costly for them when they're doing that. Office visits for consumer-driven health plans. This is an interesting slide, and one that stood out to me as soon as we got the results compiled. Given the fact that very few employers, as we see here, with the exception of those who fall in the 75th percentile on the primary care side as well as the specialist side, still have co-pays within their plan. And this is a direct reflection of truly what I believe that we have seen in the marketplace, and that is a migration of employers away from having co-pays built into these high-deductible health plans and going to an HRA arrangement, or more frequently going to an HSA arrangement, whereas we all know you cannot have any first-dollar co-pays built into those platforms. So the migration away from co-pays into having services, all services, whether that be office visit co-pays, prescription drugs, et cetera, subject to deductible and co-insurance, creating an additional layer of transparency for members. But for those of you who do still offer co-pays in your high-deductible arrangements, they're very similar to what we saw on the previous slide with PPO. So again, what we are seeing here is that migration to greater transparency and consumerism within the market, getting rid of the insulation, getting rid of the co-pays, and exposing individuals to the true cost of health care. Nothing earth-shattering on this slide here as it relates to coinsurance, but we are seeing a slow migration to 50% on out-of-network coverage, just given the fact, again, we talk about the depth and breadth of the networks that I referenced earlier. You have to try hard these days to find an out-of-network provider, and we do find that, especially in the central Indiana area. There are some specialists, and you're going to find that throughout the state as well, some specialists who just feel as though they don't need to participate in networks. They don't need to take a cut in pay because they are going to get their clientele regardless. So they traditionally do not participate in surveys or in networks. Sorry. So it wouldn't matter who the carrier or the network may be that you're participating in. Gone, unfortunately, are the days of the 90, 70% coinsurance prominence. And as reflected here, very much in line with what we're seeing on a national basis. This slide here for consumer-driven plans looks obviously a bit different than the previous slide we just looked at on PPOs, in large part due to the fact that a number of CDH plans exist that have deductibles equal to the out-of-pocket maximum. Thus, there is no coinsurance in existence in those plans. However, for those who do have coinsurance, the 80% remains to be the most prevalent for those plans on both a local and national basis. So we have plans that have a $3,000 deductible, $3,000 coinsurance that includes the deductible, and that was what I was referencing to there with the deductible equal to out-of-pocket maximum. One thing I want to bring up on this slide while I'm thinking about this, and could have brought this up on the deductible slide as well, not to get too much in the mud, but for those of you who have embedded deductible plans, keep in mind, in 2015, the IRS has migrated the minimum family deductible allowed to have an HSA from $2,500 up to $2,600. And following those terms, in order to have an embedded deductible plan, your individual deductible cannot be less than the minimum family deductible allowed. So for those of you who may currently have a $2,500 deductible embedded plan, know that we need to bump that up in 2015 unless something changes between now and the end of this year, which I don't anticipate happening. But we need to bump that up to $2,600 to ensure that we continue to have that embedded deductible within our plan. Talking about prescription drugs, from an overall perspective here, as we look at co-pays, nothing out of the norm. As we look compared to national information, we do see a spike there on the specialty RX. Some of you have witnessed firsthand that one or two or maybe a handful of your lower paid employees happen to be some of your highest totally compensated employees simply due to the cost of the RX for themselves or family members. When we talk about, again, we're talking about specialty medications, growth hormones, injectables, things of that nature. There are a lot of cancer-related medications that are extremely, extremely expensive. And those at times are certainly hard to control. You want to be able to take care of your employees and their family members, but at the same time that becomes a cost consideration and something that would encourage you to focus on when reviewing your plans. We are seeing more and more coinsurance for prescription drug plans to create greater transparency and remove the insulation from the RX copays. For example, whether this is on brand, non-formulary, specialty, or across the board, typically we still see generic falling into that copay range, but outside of that, nothing is protected territory. But going to an arrangement to say 30% coinsurance for a prescription drug with a minimum of $50 and a max of $100, whether that, again, use the example for a non-formulary or a specialty medication, where now we've created transparency for your employees. We created a coinsurance arrangement so they see the true cost of what that prescription is, as opposed to being insulated by just paying a $50 copay in a way that goes. So, for example, you have a medication that costs, say it's $100. Well, 30% of that obviously is $30, but the minimum is going to be $50 that is passed on to that employee at point of service. Now, if there's a $300 medication, we have 30% coinsurance, they're going to pay that $90, and so on and so forth, just to give you some ideas of examples there. But something I would encourage you to give consideration to as you're looking at your plan and thinking strategically for 2015. Now we'll make a brief transition here and talk about the costs of the programs that we have been discussing here and refer back to some of the historical data as well. The median cost that we see here, slightly less than a national, at just under a 2% increase from last year as well, from 2013 to 14, had about a 2% increase to bump us up to $482, but still falling just under what we're seeing there with the Kaiser average, $503. Overall. Back in 2006, again, a little history here for you, the median cost for a PPO plan for those in the survey was $304. So we have seen a 60% increase in the cost. As referenced earlier, we went from $500 to $1,000 on the deductible, and now we have gone from $304 up to $482 on the cost. Family plan has gone up a bit more from what we saw last year, about 5% increase from 2013, just as an FYI there. And what you see here on average are the family costs being 3 times that of the employee costs, which I'm sure makes actuaries proud who would tear into this data. Monthly premium for consumer-driven plans, again, talking about HRAs, HSAs, high deductible plans in general. Similar to the PPO, the local median cost is less than the national and right at 2% increase from last year. And as we see the median cost there, $411, we were at $257 in 2006, and again, an approximate 60% increase over that period of time. And you see the family rates there. Accordingly, we mentioned earlier, typically 3 times what we're seeing on the employee side. From an employee contribution perspective, interestingly, every tier on this page from the local survey went up approximately 2% on average from last year. So cost shifting is still alive in all areas, whether that be via contributions in plan designs, although we did see the plan designs stay somewhat static there with the $1,000 deductible. On an overall basis, the majority of local respondents are charging employees a greater share than what is seen on a national level. But that said, something to keep in mind, as noted on some of the previous pages, local premiums run consistently less than what is shown in the national figures with Kaiser. So taking that into consideration from a dollar per dollar perspective, not tremendously higher than again what the Kaiser results are showing there. Same holds true on the family side there, and again approximately 2 to 3% higher than what we saw for 2013. For consumer-driven plans, contribution percentage stayed nearly identical year over year. And as employers pass costs on employees, what we are seeing and tend to see is more focus on the PPO plans rather than consumer-driven plans to drive or incentivize employees to migrate into the higher deductible plans, which is evident in the survey results. So we want more folks to participate in the high deductible plans than we do the PPO plans, So how do we bring that to their attention? Well, we pass cost on to them. That's first and foremost. That's one way to catch their attention, and then provide incentives around that. Again, still higher than national averages, but all relative, as I mentioned previously, with the premium variance that we saw on the previous slide that throws the median cost sharing here very much in line with what we're seeing on a national basis. Now we'll make a quick jump and talk about the dental plans for a few slides here. And I'm actually going to hit on HMO programs in this just briefly, given the prominence that we have throughout Indiana, especially in the northern part and southern part of Indiana of HRA, for example. Delta Dental falls into this in some areas as well. But just given that that is more relative than what we see on the medical side, I wanted to touch on that briefly. Identical to last year and many years before, we haven't seen a ton of adjustment here with the median deductible being right there at $1,000, and we see that across the board there down into the 25th percentile as well. We are seeing some migration of employers into dual options, allowing employees to buy up to higher annual maximums. So we have a base plan of $1,000 annual maximum, or even $750 that's going to cover annual cleanings and exams, things of that nature, and maybe a filling or two, up to a higher annual maximum plan, $1,500, $2,000, that's going to cover more of the in-depth services and maybe also provide a benefit for orthodontia coverage. As I referenced, the HMO plans, again, somewhat scattered here as we look at the 75th percentile, but very consistent on the median and 25th percentile. But although a tighter network, we are seeing the similar benefits on a local level. Looking at the cost of these programs, we are identical. The survey median here of $27 is identical to what we had last year in 2013. This market, being the dental market, is becoming more and more competitive with the players out there, but also becoming more predictable, especially on the self-funded side as well, to be able to manage the costs and with great predictability to be able to keep those costs consistent. And hopefully, folks aren't going to have to incur extreme amounts of dental expenses year after year, and this can be cyclical in nature. Some years it's high, some years it's low, but overall create some consistency in those costs. Here is where the impact of the dental HMO plans comes into play here. As you can see, compared to the previous slide, the costs on average are 15% less via the dental HMO plans than they were for the PPO plans. So benefits may be somewhat consistent, but we have a tighter network, better able to manage those costs and drive down the premium that is passed on to the employers and the employees. Now we'll switch gears a bit and talk about some of the other benefits and some of the other questions that were asked in the survey, getting beyond medical and dental plans and talking about life disability programs that we'll get into in more detail here. As you see, we have a long list here of other benefits that are offered by employers in the market. Basic life and AD&D, that's very traditional. As many of you do that, if not all of you, whether it be a flat amount, a multiple of salary, and then also offering the ability for your employees to buy up with supplemental life insurance or dependent life insurance. Nothing that stands out or is glaring on this page is something new compared to what we've seen in the past. But one area that we see of tremendous growth is you get down in the lower third of this, critical illness, cancer policies, accident policies, to add to that. We are seeing an increased interest in these programs to help ease the burden of some of the higher deductible plans that are being passed on to consumers. So someone is faced with a $2,500, $3,000 deductible plan. The concern often is what if something happens to me? What if something happens, our plan year's calendar year, what if something happens to me on January 15th? I don't have any money in my HSA account to offset the cost of this. Well, here's a way to help ease the burden, ease the concern that they may have in offering critical illness, accident policy for those who may have a bunch of little kids running around that like to get into trouble and end up in urgent care or ER. It's get a handful of stitches. Accident policies come in handy. I can speak firsthand from that. But that is where we're seeing some interest in. We're also seeing employers providing this coverage and paying for this coverage on behalf of their employees when they're transitioning to these high deductible plans, again, to help offset that concern and ease the burden that the employees may be facing for some of these. Down at the bottom, long-term care, that is another one that we are seeing with growing interest. A lot of discussions, more discussion now, I would say, than ever before, and having a handful of employers roll that out to their employees. This is one that gets extremely technical in nature, but there continues to be a lot of interest in this category. One that doesn't fall into this slide is pet insurance. We had that a few years ago, but unfortunately I guess that has faded. So for you pet lovers, there's still options out there. It's just not being offered through your employer as it may have been in the past. LTD elimination period, what we see here most commonly is one that falls into the 180-day category. That's where the vast majority of employers fall. Obviously, 90 days being the most prevalent there, with another 25-27% falling into the 180-day category. And again, nothing outlandish that we haven't seen in the past, and no big changes here, other than we have seen some migration into making LTD a bit more voluntary in nature, or at least a bit contributory in nature, as folks look to continue to maintain the affordability of their medical plan. Short-term disability, the elimination period here, the majority of folks, again, falling under that 8-8 category, so 8-day accident, 8-day illness, where the benefit kicks in, a few falling in up to that 15-day accident, 15-day illness. But the majority, what we see, I would say, again, what we see consistently on a local basis is that lower end for accident and maybe a week for illness, which would fall into that red bar there that we have on the very left. A few more details on those coverages. 86% of base plans replaced 60% of salary for long-term disability programs. 44% offer benefits to age 65, and the vast majority of the respondents pay 100% of the base cost. And I mentioned that earlier. We're seeing some migration, as this number has decreased a bit over the past few years, but the majority of employers still paying for long-term disability as well as short-term disabilities. You see down there at the very bottom bullet, 75% paying 100% of the base cost, 73% offering at 60% of benefit, and then seeing the benefit duration there of 13 weeks and 26 weeks, or some composition thereof in between, and make up whether it may be a sick pay program or whatever other program you may have within your organization. So for now, that is it as it relates to the medical, dental, and insured programs that we traditionally talk about in the survey. But at this point, as I mentioned earlier, we have Nicole Fallowfield, who is our Director of Health Risk Management, joining us to walk through some of the trends in health risk management, walk through the survey results that we have here, and getting into some of what she's seeing in the marketplace and what she is talking to employers about. So, Nicole, if you are on, I will go ahead and turn this over to you at this time.
Thanks, Wes. I am here. Can everyone hear me? Can you hear me?
We hear you. Fire away.
Awesome. Great. So the next couple of slides will demonstrate the results of the survey as far as what wellness programs are being offered by those who answered the survey. So that's the gold bar compared to the 2013 Kaiser survey data. And then we will wrap up with my section, as Wes mentioned, on what I'm seeing are current trends right now with wellness and health management, and then what I see is coming soon as far as the future of wellness is concerned. So you can see here there are a list of items to select from as far as what employers are offering as part of overall wellness initiatives within their workplaces. And those are things like flu shots, newsletters, web-based resources, tobacco cessation programs, etc. One of the things that our survey respondents were offering more frequently than some of the Kaiser participants were actual biometric screening, so those on-site health testing, as well as programs and gym memberships and fitness facility reimbursements. So that's really encouraging because I do see even more employers doing some of those things, especially in the realm of employee assistance programs, so that mental and behavioral health component, and then certainly more interest in gym membership reimbursements and offering classes on site for exercise. The next slide looks at incentives, and you can see the percentage of employers responding to the survey. Just a little less than 40% said that they're offering some type of incentive versus significantly more in the Kaiser survey indicating there is an incentive being provided. However, you will see a difference in types of incentives. The Kaiser respondents weren't offering as many incentives tied to the health plan as the respondents to the Gibson Guide Point survey. And you can see the most popular things are lower employee medical contributions, gift cards, cash, merchandise, maybe even employer logoed materials. And then you can see where the Gibson respondents are certainly ahead of the game, where they are maybe contributing to an account-based plan, so an HRA or an HSA contribution for wellness participation. And then certainly some lower deductibles as well. As far as disease management programs are concerned, and keep in mind those are things that are typically offered through the health plan. So usually the carrier is offering that type of service, or you're purchasing it through your third-party administrator. Sometimes we might see an employer that's partnered with a third party that specifically has an expertise in disease management, like a company like Healthways, but that is probably not seen as frequently as what's being offered within the health plan. And you can see here that the majority of the respondents to, well, nearly half of the Kaiser indicated that they're not offering any type of disease management, and certainly less of the Gibson respondents indicated that disease management wasn't being offered at all. The most common disease management programs you can see there, diabetes, asthma. A step further on that would be coronary artery disease, chronic obstructive pulmonary disease, congestive heart failure. Those are typically the top 5 that are offered, especially within fully insured plans that the carrier will manage on behalf of your members who have those conditions. We've started to see more disease management providers address high cholesterol, depression, obesity, high blood pressure, and low back pain within their disease management program offerings. As far as incentives for disease management is concerned, though, that's one area where typically employers have not provided an incentive. You can see the majority of the Gibson survey respondents indicated that there aren't any incentives for members to participate in disease management, and so that's not something that I wouldn't expect to see. That's pretty typical. Although there are a handful that say that they do offer cash or gift cards, and some of the fully insured plans have incentives built into the disease management platforms. And then you can see there just a smaller percentage maybe offering things like an HSA or an HRA contribution for participating in disease management. As far as health risk assessment incentive programs are concerned, this is one area where sometimes health risk assessment combines not only the questionnaire piece with the biometric piece. So depending on how you answered that, some folks incent both of those pieces, the actual questionnaire piece, and then some choose to only incent the biometric piece. But you can see only about 18% said that there was no incentive provided, and then the list goes on again from employee medical contributions, a discount on your premium being the most common type of incentive for health risk assessment, followed by cash and gift cards, and then again that HRA and HSA contribution keeps showing up in that list as far as being a popular way of providing an incentive for wellness. So the next couple slides, we'll talk about some wellness trends and certainly some current trends that we're seeing out in the market. there has definitely been an increase in outcomes-based incentive type of programs. And by outcomes-based programs, we mean incentives tied to achieving a particular health standard. So, for example, if your blood pressure or your cholesterol or your blood sugar is within a particular guideline, offering an incentive based on those outcomes. Certainly, the trend has already been on an upward trajectory over the last couple of years, but we've definitely seen an uptake in this most recent year as a result of the provisions within the Affordable Care Act wellness guidelines that allow employers to provide more incentives for those types of outcomes-based programs. Part of an outcomes-based program, too, the tobacco user versus non-tobacco user falls under outcomes-based, and I've certainly seen that is an area where employers are adding an extra layer of incentive or disincentive, depending on how you view it, for people who identify as being a tobacco user versus a non-tobacco user. One thing I do want to mention about those outcomes-based incentives is that you have to be very careful about making sure, first of all, that you're in the provisions within the guidelines within what you can actually provide the incentive for, so the total dollar amount available. And for outcomes-based incentives, that's up to 30% of the total cost of employee-only coverage or the incentive category for which it applies. So, for example, if you offer an incentive tied to outcomes for your biometric screening and the employee and spouse who are on the plan can both participate, then it's 30% of that coverage, your employee-spouse coverage. Only the employee is eligible. It's limited to 30% of the total cost of employee-only coverage. And then with tobacco, you can add an additional 20% to that incentive amount for a total of 50% of the total cost of employee-only coverage between the two categories. If it's tobacco only, you have a little more room to provide an incentive. So if you're not providing incentives for employees to meet certain biometric criteria, but you do want to reward those who are non-tobacco users or penalize those who are tobacco users, it can be up to 50% of the total cost of employee-only coverage. So there's certainly a lot more room for employers to provide incentives for those categories with the new provisions within the ACA guidelines. One of the things that we have seen is, as we've seen employers move from traditional PPO plans to offering consumer-driven health plans with either an HRA account or an HSA account, we've seen movement from premium contribution incentives to account-based incentives for wellness. And so employers are typically, when they have those types of plans in place, instead of offering a lower medical premium contribution for participation or meeting a certain outcome for wellness, they are offering those incentives in the form of an HSA deposit or an HRA deposit into the account for achieving certain participation requirements. We're also seeing a move more towards personalized wellness, and that's a result of, for most employers, because it's a result of having had a wellness initiative in place for many years, and they've sought feedback from their employees and their participants, and commonly they are hearing that people want it to be a little bit more personalized. So I've seen a shift towards that. With technology, the advancements in technology from a web platform for wellness, that's one area where this makes, where personalized wellness becomes more practical for employers to be able to implement, because a lot of the tracking can be done via that web platform, and a lot of the personalization happens as a result of how people answer the questions, how they answer their level of interest, their level of willingness to engage. And so we're certainly seeing a trend more towards making wellness a little bit more personal to people. And then the last bullet point is a current trend, but it's also one, and I didn't put it on the next slide, but it is one that I see as continuing into the future, and that's employers offering either on-site, near-site, or shared primary care clinics. And we started to see a trend in that several years ago. Schools have been an early adopter of that, and part of that is due to the provision within the state for meeting certain costs for health care. But we're starting to see other employers gain an interest in having these types of services provided on-site for several reasons. One, a transactional savings, so you're purchasing health care at a wholesale versus retail rate, but also from a productivity standpoint, just knowing how difficult it can be for employees and members on the health plan to get an appointment, the time that's spent in a physician's office, and the lack of time once you're there actually conversing with the provider. So we've seen many employers that are interested in the concept, that have investigated the concept, and then are implementing the concept of bringing primary care to the workplace as well as acute care to the workplace. As I mentioned, I do think that that is one that we will see continuing into the future. I think part of the reason we will continue to see that is you can't go a day without reading or hearing on the news that there's a shortage of primary care physicians. And as more people become covered under the Affordable Care Act, we anticipate that that shortage will only increase. The reality, too, is that not many physicians that are in medical school are going on to have residencies in primary care. Many of them want to practice in a specialty, so we have that shortage for that reason as well. And for the ones who are in the field are starting to retire, and that becomes more of a concern for employees, employers, and anybody on the health plan that access may be limited. So again, I think we'll continue to see a shift towards employers at least investigating the efficacy of offering some type of primary and acute care at the workplace. I also think we'll start to see less focus, and I'm seeing this now, and I'm talking to our clients about this, but less focus on physical health and more focus on well-being. And traditionally, if we look at what traditional wellness has been and how the industry has talked about wellness and health promotion, population health management, you'll hear all of those terms kind of interchanged. There's been a very specific focus on physical health, and for the most part, a lot of that was due to the fact that employers continued to see healthcare costs rise. They continue to see that there is a small percentage of the population driving a lot of those costs, and that when you look at the research, a lot of the research indicates that many of the conditions that drive high costs are those chronic conditions, and they can be prevented. So, of course, when wellness was traditionally rolled out, there was a very strong focus on that physical health piece. Well, the more the research is developed, the more you look at how is a person's overall health impacted. We can't just isolate the physical. So I think you're going to start to see, and you'll hear more about this term well-being. And really what that means is that a person finds their daily work life is fulfilling, they have strong social connections, they have access to necessary resources, they're financially secure. So well-being is beyond just the physical. Certainly the physical is a part of that, but it goes well beyond just physical health. So really you could divide it into about 5 categories: purpose or career well-being, social well-being, community well-being, financial well-being, and physical well-being. So expect to see a lot more of that, to hear a lot more about that in the future. If I'm currently working with you on your wellness initiative, you're going to hear me talk a lot about this. You'll also start to see, and I think we're going to continue to see, a shift in the focus on culture of health to organizational health. So by culture of health, I mean those things that many of you have already done within your workplaces to try to provide a supportive workplace environment to make the healthy choice the easy choice. So things like offering, healthy snacks in the vending machine or in the refrigerators, providing on-site fitness classes, having a tobacco-free workplace, all of those things that make a healthy culture within the workplace. But I think we'll start to see a shift to organizational health. And think of that as organizational well-being even. So that the organization is functioning in a way, in an optimal way, where people feel good about going to work, they feel supported in their efforts from a health standpoint, and really where it will mirror some of those components of overall well-being. So I think that will certainly be a shift. And the next bullet point, extrinsic versus intrinsic motivators, there's been a ton of debate about the ROI around wellness programs. And a lot of that has been due to the fact that most of the studies that have been done have compared active participants to non-participants. And so if we look at the way incentive plans are designed today, a lot of those are extrinsic motivators. And that's not to say that people aren't enticed by, I can achieve, extra dollars into my HSA account if I do X. There's certainly some level of motivation there. But ultimately, when we're looking at, again, that well-being, the overall well-being of a person, whether or not they're going to get an additional $100 for having a blood pressure at a certain level is very much dependent on that internal, that intrinsic motivator. So that has to actually be a priority to the individual. So I think we're going to start to see incentive plans evolve to where they try to address the areas that are important at the individual level. And that goes back to that other trend I discussed where wellness is becoming more personalized. And then ROI gets a new perspective. As I alluded to before, a lot of the studies that have been done have compared active participants to non-participants. And so certainly you would expect that those people who are actively engaged in their health are going to show that they're on their health care, and that's true. So now the real focus is going to be more on not what is that return on my medical plan, because one, it's extremely difficult to measure, and two, if now the research is indicating that, well, it's probably not a real valid comparison because you're not comparing two of the same cohorts, then the new perspective is, what does it mean to your organization to have people who are engaged? And so I think you're going to start to see a shift from ROI around wellness to, again, that organizational health, overall well-being, and employee engagement. So with that, I'll turn it back over to Wes.
Terrific. Thank you, Nicole. Thanks for the time and information and great perspective. There's a lot to take into consideration as we're looking to hone in on our wellness strategies going forward, so we certainly appreciate that. And on a go-forward basis for all of you on the call, if there's ever any questions that you have, feel free to filter those back through us, and we'll certainly get Nicole involved to provide her perspective on what you may be considering. So thanks again, Nicole, for being with us. So we're in the home stretch. Next 5 minutes here I want to spend talking about some of the general market trends, getting beyond wellness, and just general trends that we are seeing in the marketplace. Some that have been around a while, some that may be relatively new to you, but wanted to bring those to your attention while we are all together here this morning. Advocacy, cost, quality, transparency resources. We've talked about these for a number of years now. Some of you on the call this morning have these in place. Compass, for example, professional health services, Castlight is out there. But as we migrate more and more and more to these high-deductible health plans, we need to be able to equip employees in making more educated decisions. And in general, even without that, we still need employees to make more educated decisions. So having access to cost and quality information to make those educated decisions is key, not only for good morale for the employees, so it's not going into this stuff blind, but to also help manage the costs of the overall program. And further, these organizations, these independent organizations, also provide a tremendous amount of advocacy in helping your employees navigate the healthcare spectrum, from assisting during open enrollment to helping them find a doctor, helping them determine the most cost-effective pharmacy, things of that nature. There's a wealth of information that these firms bring to bear. One of the newest trends, this has been a buzzword, and it's hit the West Coast on a very abbreviated basis, but is reference-based pricing. This is one that I can tell you we're excited about. It's quite a ways from hitting home, I believe, here in the Midwest, but it's certainly one that we have on our mind in thinking about, and at least having discussions with. Theoretically, this is what this will look like once it finally comes to bear. But again, we're talking about reference-based pricing. So, for example, say the cost range for an MRI, and this isn't out of whack, say the MRI of a knee or something, say it ranges from $800 to $2,400. The throughout the state of Indiana. Well, we as an employer are going to sit down, and there's some work that goes into this up front, but we're going to work with the vendor. We're going to have multiple parties involved to help set our pricing point. But let's say that we believe that $1,400 is a fair price for an MRI, and based on what we see in the information shared throughout the state of Indiana. Now, quality isn't necessarily a huge concern as we're talking about MRIs, but cost, we believe within reason there are enough facilities that our employees would have access to that fall under that $1,400 price point. So someone goes, gets an MRI, costs $1,000. That is going to be paid according to plan. It's going to be deductible coinsurance, and away they go. It's just traditionally how the process has worked in the past. However, if they go and have an MRI done that is $2,000, now we've exceeded that $1,400 maximum by $600. The plan is still going to function as it would traditionally up to that $1,400 point, so deductible coinsurance. Beyond that, and in excess of that, that $600 difference, the employee is responsible for that entire amount. And there was some legislation that came out within the past month or so that states that that additional amount does not accrue towards a member's out-of-pocket maximum. There were some red flags raised due to IRS concerns and limitations as brought forth via healthcare reform, that if these were to fall outside, we may have an issue. But as of a few weeks ago, there is some verbiage out there that says, nope, we are in the free and clear to exclude that from the out-of-pocket maximum. Now, there's certainly going to be more to come on that. But that is one area that we are extremely, I would say, excited about. It's an intriguing way to help change the landscape of what's going on and how people actually purchase health insurance. Not only providing them, this would be in concert with advocacy and transparency resources. So we're providing them with the education and information, but we're also giving them a price point to say, hey, here's where the buck stops. Beyond that, it's up to you. What we're also seeing in the market, healthcare utilization is down quite a bit, and we're seeing the direct results of that when we hear the healthcare systems and hospitals in general going through layoffs. I can tell you in central Indiana, for example, those hospitals there are showing double-digit decreases year over year from 13 to 14 in similar time periods of utilization. So in turn, obviously revenue is down for those hospitals, but as a result, insurance companies are making a ton of money right now. And I'm not here to beat them up. They've played the game. They've been in this for the long haul, and they will continue to be, but they're making a lot of money because utilization is down so low. And we see this as being truly a result of consumerism. Indiana, some of you may not think of it as leading edge, but we are truly ahead of the curve from a funding arrangement, a lot of employers being self-funded more so than what we see in other markets, and also into consumer-driven health plans a lot more heavily than what we see in other markets. And as a result, people are thinking twice about what they're doing. Do I go to urgent care instead of the emergency room, or do I wait till I can get in my primary care doctor instead of going to urgent care? In general, do I even need to go? And so outpatient utilization is down. Inpatient utilization is down, which wouldn't necessarily be a direct result of that, but also maybe folks are trying to go over the counter to take care of things more so than what they've done in the past. And further, what we're seeing is a greater access to convenient and urgent care facilities. Up here in South Bend and in Warsaw, Physicians Urgent Care is a new organization that is coming into market. It recently opened urgent care centers within the past year. And we are seeing this emerge in other markets as well, to where there is not much access that exists in terms of alternatives to going to an emergency room. So where there is being this access provided to go to an urgent care, we are seeing greater utilization of those facilities, which transitions into lower costs in general from the healthcare marketplace. This is new. Nicole talked about the on-site clinics, not foreign to many, if any of you, but it's new, but will continue to also have an impact on healthcare utilization as people go direct with their employer, if you will, to receive healthcare. Obviously, going to primary care, urgent care, for example, those utilization numbers are going to continue to go down, as well as managing the overall health of the population can help mitigate that from getting into hospital facilities. Medicare cost plus pricing, another trend that we're seeing in the market, and this is on a one-off basis. If you want to spend some more time talking about this with us, we'd be happy to. But this is for those employers who are looking to go or may already be in a self-funded environment where the program will reimburse facilities a Medicare allowable amount plus call it 15%, 20%. And we maintain the physician network, so folks still have access to pediatricians, things of that nature, the doctors that they're most comfortable with, but we are eliminating a facility network and reimbursing those facilities at Medicare cost plus a certain amount and seeing tremendous savings in the analysis here. Now, the concern is, and I'm abbreviating this tremendously for the sake of time, but the concern is the potential liability that is passed on to the employees, because they are going to get bills from the facilities that say, hey, you know, the charge was $30,000. We've only been reimbursed $7,500. You owe us $22,500. Where's our money? That is then handed over to the fiduciary, co-fiduciary of the plan that works in concert with the TPA to help run interference and manage that process for the employees. And again, I have extremely over-abbreviated that, but it's a market trend. It's catching hold here in the state of Indiana. We as Gibson have known about this for about 4 or 5 years now, and it started with a group out of Texas. So we've had some general discussion. It's not one that we are product pushing in the marketplace by any means, but wanted to bring this to your attention because a lot of the mid-year strategy meetings that we'll be having with you, this will be one of the items that we're talking about, just as an FYI of what is going on in the marketplace. So we are now at the top of the hour. We are right at 10 o'clock. I believe there were about a half dozen questions that came through here while we were on the call that I tried to address as best I could. If you have individual questions that you did not write in, or you just want to discuss with us on a one-off basis after this call, feel free to reach out to us directly. As always, happy to help you. And be on the lookout at some point today for the individual report that will be hitting your inbox. So once again, thank you very much. Thank you for your time this morning. Thank you for your time in participating in the survey. Thank you for your partnership. We greatly appreciate it. There are a lot of challenges to come aside from healthcare reform, but in general, and we're here to help you every step of the way. So thanks again. We appreciate your time. Hope you have an awesome day today, and we will talk with you soon. Take care.